which is Tibial nonunion by Dr.Chittawee Jiamton. Dr. Chittawee, please.
The most simple one for the last. Okay, this is tibial nonunion. The patient, she was 30 years old, female. She got an ankle pain for 8 months. 8 months, she was accidentally shot in her distal leg. She got like an open fracture of the distal tibia and fibula, and she was underwent debridement and immediate OIF. Until now, the doctor did not allow her to bear her weight fully. No underlying disease and no history of the wound complications. This is the previous surgical scars on the anteromedial down to the medial side of the ankles. And there is a lateral incision over the fibula. And this is the X-ray. Sorry, I don't have the initial X-ray, and honestly, I don't have any consecutive X-ray. This is the X-ray when she went to our hospital. Okay, you can look at it carefully and just symbol, what's your plan?
Yeah, Dr. Dilek, please.
So I would say this is a non-union that come with the deformity. So to set this goal, so first I would rule out the infection first. Is there any infection before, or any signs of infection that I need to consider before proceeding to everything? So, and I would do the physical examination to see is there any like a deformity and also the adjacent deformity. When the patient is a long-term wear loss of the ankle, some patients got a subtalar accommodation for vulgus. So is it stiff or is it mobile? So what I do, I set a goal to first collect deformity. Second, get it healed. The third is get the motion back. Like maybe it is in equinus, that a bad equinus. And so I would do the soft tissue procedure after everything all healed. So what I would do the planning for deformity correction and do the bone grafting, and the plate is for 8 months. So I usually consider about the metal has a memory. So if it's used for a long time, it might doing well after we use it for another like 6 months.
What is the motion of the ankle?
Actually, we can do passive dorsiflexion up to 20-degree relax for 2 plantigrade, just minimal equinus.
When I look at the AP X-ray, I think there are also tilting of the ankle.
Okay.
In every case of non-union, delay union, you have to check about deformity, because you are not treating only non-union or malunion. Sometimes you have to treat that kind of deformity of the ankle joint. Otherwise, you can achieve union, but the ankle joint will be, traumatic arthritis. So I need the weight bearing to calculate whether I need to correct that valgus, right? That's one point. The other point is about the soft tissue and the plate. The question is, if you do the corrective osteotomy in case of this, shall you use the previous incision from the middle one? That is another issue. Is the soft tissue is good, you can go right there, and you need a lot of bone graft because there's still some dead bone in that area, because you can see the density of the bone. So you have to remove all this dead bone and replace with a good bone. So I think this is probably if you leave like this, the plate will break. So it's better not to wait longer, but then you have to decide how you're going to approach this and how much deformity you have to correct.
Okay, any more comments, or I can proceed to what we have to proceed? Okay. I try to list the problems This is a gunshot wound with distal tibial, maybe non-unions. Yeah, we need to consider about the infection, is it infect or non-infections. We can appreciate that there is some tilting or vallus of the ankles. There should be some metaphysical bone defect after we remove the dead bone when we open to correct the deformities. And there is not fixed equinus ankle, but anyway, there is some like equinus ankle. So I try to classify my non-union. I will determine its needs regarding to alignment, biologies, or stabilities. And yes, we should evaluate for any infections. And we also should to evaluate for any abnormalities like in the metabolic derangement. So I think our case is atrophic, non-union. We cannot see any callus. If you look at the alignment, it's vallus. If you look at the biology, it should be impaired from the initial injuries. It should be impaired from the previous OIF. The stability might be not that proper for the fixations. There's many screws inside the defect. So I'm thinking about should we need to change to the longer plate or revise the screw in appropriate positions. I have already worked up for infections and also calcium and vitamin D deficiencies. Other consideration is the skinny soft tissue on the medial side that I don't want to do anything much over the medial aspect of the ankles. There's some equinus I have to do reconstruction later. And there's also rigid fibular fixation, which might be the problem. So this is our plan. We will correct the stability and biologies from our classifier as the atrophic non-union. We will try to collect the vallus using the articulating tension device. We will put bone graft. We will create more appropriate fixations. And what we have done is, because I don't want to open everything out, I don't want to open the medial side of the ankle, I just open to remove the proximal screws. Everything in the distal part is more or less okay. So just put the distraction device to correct the alignment first, and then remove all the dead bone. The proximal part, after you get the proper alignment, you just put the screw in and fill the metaphysical bone defect with the bone graft. And yeah, it heals without bone wound complications. And she still got some equinus, which I have done with percutaneous DA lengthening when she want to remove the plate. And this is the final result. Yeah, just take home message as we have already evaluated.
Dr. JP, any comment?
Yeah, just one comment. Everything you did was really good and in the right sequence. I would have probably done the TA release at the same time when I revised, because keeping it in equinus may have added to the stress.
Okay.
Of that area. So that's the only thing I would have done differently.
Okay. Yeah. At that time, my concern is if I do lengthening at the initial state, I need some immobilization with the cast or something like that, which it may be, yeah, I want to observe the wound, just that.
I would have done the same.
Yeah.
Did the TA release, then maybe put an AFO just to protect.
Yeah. Thank you. Okay, that's all for the case.
Thank you, Dr. Chittawee. I would like to emphasize on how you, pre-operative planning is very important. Then you can get a good result. So may I ask any questions from the floor on our cases? You can ask our panelists. Okay, no question.
No question. So thank you so much for our panelists, our presenter, and of course, all of the participants that you stay with us until the last session of the meeting. And see you guys again next year in Chiang Mai. Have a safe and nice trip back home. Thank you so much.
Good luck and thank you.